Namaskar. Welcome to the Presidential Initiative Gyan Pravah podcast series. Today is episode 296, a moment to celebrate. And I am Dr. Archana Kumari, Chairperson, Quiz Committee Fogsi, who is the host for podcast on 20th of every month. And today I'm extremely honored to share my screen with two powerful, power-packed personality, Dr. Sunita Tandulwadkar, the president of Fogsi, and Dr. Justin Paul, who is known as father of Cardio-Obstetrics in India. He's an eminent professor in Madras Medical College. And very rightly, we'll be having the engaging discussion on the topic, Bridging Hearts and Mothers, the Rise of Cardio-Obstetrics in India. But before that, before we start our conversation, let me formally introduce and welcome our President Fogsi, Dr. Sunita Tandulwadkar, Madam.
Archana, no introduction of mine to our own
Just
people.
a little bit, Madam, for Sir. Actually, I briefed Sir during our pre-session, but of course, Sir, Madam is the president of Fogsi, which is the largest organization of 46,000 members. She is a multitasking, a woman of substance, a president with power, passion, and purpose. And she is leading Fogsi with her mission, with so many projects. And the most ambitious one, as I was telling you, is the preconception care, the Swasth Janm Abhiyan, which is optimizing preconception care. And she is so multi-talented, multitasking, be it endoscopy, be it high-risk obstetrics, be it fertility, and regenerative medicine. She's very passionate about stem cell research. Sir is also an eminent researcher. So Madam has the credit of having the world's first stem cell baby. She is also the president-elect of ISAR. And she is a great organizer. Recently, we had the conference, the presidential conference at Pune. It was named as Star Sampurna. And we were actually treated like stars. She has class in everything with wherever she
Archana, thank you.
organizing.
Today is the platform for you with Paul, sir. And I'm so
I
glad
welcome you, Madam, for your address.
because unless I rope in, you will not stop, and I feel awkward. Today is the day of you, Archana, with Dr. Paul. Thank you so much for coming on a Foxy platform, sir. This is 8 p.m. Every day we do the Pravaha. This is a podcast series we started on 29 January after we took over as a president Foxy. I have a 30 dedicated chairperson. So on 20th of every month, Archana will come and she will have a dialogue with the interesting personality, maybe academic, non-academic, which will be of a great use to the society at large because it goes on a YouTube. Maybe Archana will share you the link after this and you can share to many more because I see it is an academic discussion and I think it will be useful to the gynecologist as well as to the cardiologist as such. And I joined 8 p.m. just to show our respect to you, sir, the faculty who join, who gives their time to Foxy, and it adds on so much value to our podcast series. So thank you so much for joining, and thank you for being on a Foxy platform. Archana had sent me the complete CV of you, and it was honor to interact with you and be in one frame with you, sir. Definitely would love to meet you sometimes. Tamil Nadu is very much advanced in a stem cell. I think Tirunelveli group, I have read one meta-analysis in 2022 on a cardiac, where the stem cells for cardiac patients, the Tirunelveli group had written the meta-analysis.
Nice.
They have taken all projects.
I am from Tirunelveli.
You are from?
Tirunelveli.
So whether you are one of the author, I don't know the people.
No. I live in Chennai now, but my native place is Tirunelveli.
Tirunelveli.
Foxy is very active.
I know. And Tirunelveli Cardiology Group has, I read stem cells in all the subject, not necessarily OB/GYN. And 2022, they have written a beautiful meta-analysis. I'll send it to Archana, who can share with you, sir, where they have taken a lot. and the 4 ways in which we put in, and various projects the people across the world have done. They have done it. Archana, I'll post it on our VP group, VP
Okay, ma'am.
chairperson group, and please share to sir.
Yes.
And would love to do some research work in this field with you, sir. Lovely to see you and lovely to meet you. We'll catch up sometimes in person.
Sure. It's a joy to have you.
Thank you. Now I'll join the viewers link and both of you will be there. Archana, I'm tremendously proud of you. You are very dependable, sincere, and you are an asset to Fogsi, dear. You are a great asset to our organization. Thank you. Thank you,
ma'am.
God bless you.
So now, ladies and gentlemen, it is my privilege to formally introduce Dr. Justin Paul, who is an exceptional clinician, researcher, national leader in cardiac and maternal health. Dr. Paul is a professor of cardiology at Madras Medical College and state nodal officer in Tamil Nadu's Heart Attack Management Program. An academic achiever throughout, he completed MBBS with 5 gold medals and 11 distinctions, followed by MD, DM, DNB in both medicine and cardiology. He is widely regarded as father of cardio-obstetrics in India. Dr. Paul pioneered multidisciplinary model that transformed the care of pregnant women with heart disease. He established the world's largest single-center registry, IMPACT, and created the largest national registry of pregnant women with heart disease, now leads IMPACT India across 56 centers. And I'm privileged to be a part of this study as one of the site PI from RIMS Ranchi. His efforts have helped create 85 cardio-obstetric units across the country and earned recognition from British Medical Journal as the best maternal and child health team from South Asia. Dr. Paul has architected Tamil Nadu's revolutionary heart attack management program, connecting 20 cath labs with 200 hospitals. He authored state's cardiac care protocol and contributed to reducing the cost of coronary stents nationally, improving access for millions. A prolific academician with 125 publications, major research grants, and multiple Best Doctor Award. I'm not reading it out separately because that will consume so much time. Dr. Paul stands as a true visionary in Indian healthcare. So, ladies and gentlemen, please join me in welcoming the distinguished guest faculty, Dr. Justin Paul, and we are starting our conversation. Sir, welcome. Your journey from Tirunelveli to becoming father of cardio-obstetrics in India is extraordinary. So could you share what inspired you to integrate cardiology and obstetrics, the two seemingly different worlds?
Well, my inspiration, I'll say that it came from the clinical reality. So as I joined as a young assistant professor of cardiology in Madras Medical College way back in 99, 2000, I saw these women with heart disease going through pregnancy, falling down the cracks, and they're perishing like sparrows. The cardiologists were giving their best. Obstetricians are doing their best. But the system was not designed for them working together as a team and partnering with the patient to ensure that she gets the best of care everywhere. So, and again, if you look at the Indian data, we hardly had any prospective data from India, and there was hardly any guidelines. So the focus was hardly on cardio-obstetrics as I got trained in cardiology, DN, and the amount of hours somebody spends in cardio-obstetrics for both the physician and the cardiologist was so meager. So we had to know a lot of things from obstetricians, and obstetricians need to know a lot of things from cardiologists, So that is the kind of gap that we had. And this gap seemed to affect the patient care. So what I felt was if we all can join together and do something, that it was a process, when we started, that is how I realized that working together as a team and caring together for the patient as a team will really help the patient. And we have seen the benefit of it.
Yes, sir, definitely. Your efforts are into fruition now. But what was the turning point when you realized that pregnancy-related heart disease required an entirely new multidisciplinary approach?
Well, as I've been seeing them, and I used to read and find out, is there something that we can do for these patients? So I felt certain way of treatment will be good, but then there'll be 6 professors. Each of them will be having their own way, whether on the OBG side or the cardiology side. So there was so much of differences in the way that we were handling the patients. There was hardly any protocol because there was hardly any Indian guideline. There was hardly any Indian data. So, and these patients, they do come with their own problems because, when they suddenly they realize they have a heart disease, they face so much of problems in the family, in the society, in the in-laws house, everywhere. And they get it and come into the obstetric clinic as the 400th patient of the obstetrician for the day. They hardly will be able to get time for a compassionate care. So much of work is there. So I realize this patient need a lot of counseling and probably some counseling with the social health worker. All need to be a part of it. So when particularly patients with prosthetic heart valves, I was realizing that many of them were getting into difficulty because of a care process was so widely different. So this was the time I realized that if we interact with the obstetricians and talk to them, and they talk to us, and we work as a team, we realized practically many of them we could save. And that is how we started collecting the data. And during the process of collecting data, we learned a lot of things. And that is how I think in 2016, when we started the basic Madras Medical College data, we realized we need to work together. That was the time I didn't even hear the word cardio-obstetrics. We were doing something as together, and that slowly over a period of time, in the rest of the world, the cardio-obstetrics was developing. And it is not that it was unheard of in India. People are doing it in pockets. But then this was my turning point when we started the data collection. We realized how badly we need to work together.
Yes, sir, definitely. Cardio-obstetrics word actually the cardiologist and obstetrician has to come. But of course, you have pioneered cardio-obstetrics movement in India. But could you just tell us how it all began at Madras Medical College? And didn't you have any challenges in starting these kind of unit or this kind of new approach?
It is not that challenges. I mean, of course, there will be challenges when we start anything new because the system is not tuned to working together as a team. We have 6 different units, and cardio OBG will have 6 different units. Each of them will be coming in together one day. There will be already an existing process of care, and the process of care is driven by the knowledge of the institution, I mean, particular unit. So, and their knowledge base and their experiences, all of them are senior experienced professors, and they are giving their best for the care of the patients. Now, when we have to work together as a team, we had to, I took some inputs from our heart attack management group, where how we created the social media platform, where we had the hub hospital and the spoke hospital as a team where they could share the ECGs and the hub hospital cardiologist could give the input. So we started working together, creating social media groups where, because we are far apart. In our institution, we have 2 OBG institutions, the Institute of Obstetrics and Gynecology at Egmore and the Kasturba Gandhi Hospital at Kasturba Hospital. These 2 places are about 4 to 5 kilometers from our main center, Madras Medical College, where we have the cardiology care. Then how do we network together? This distance itself was a challenge. And we don't even meet each other. We don't even meet each other's, hardly know each other's name. So we finally, worked as a process of data collection, process of follow-up. We worked together as a team, and we created a group. We started discussing, we started calling each other, talking to each other. When we realized that the cardiologists are willing to, wanting to talk with the obstetrician, they were so more than happy to reciprocate because they also really want to get inputs from the cardiologist. So same way, that is how we started working together. And when and every director of Institute of Obstetrics and Gynecology at Kasturba Gandhi Hospital were so helpful. Where in fact all of them are active members of Fogsi. I don't know. Of course, you will know all of them. So they all were so supportive. The entire cardiology community from the Madras Medical College, Rajiv Gandhi Hospital were so supportive. And that is how, we could develop that impact registry. And we had a very nice postgraduate who's now partnering with me. So she will visit every patient, get the follow-up, and meet the OG team. And that is how, we connected the gaps and started the bridges.
So I also believe that this talking directly helps a lot. The consultant level talk, if you talk directly, if you are having some problem, I also call the cardiologist directly, and it is then becomes a teamwork. Sir, actually, the MPEC registry is the world's largest single center registry on pregnancy and heart disease. So, what have been the most surprising or impactful findings so far? Which we can
Most surprisingly, we had a lot of impactful findings. But the surprising finding was that we realized that 60% of women with heart disease know that they have a heart disease for the first time during pregnancy.
Yeah, that is very true.
Imagine a lady marrying somebody and they both so happy it is becoming, she's pregnant, and they go for a counseling and the doctor tells you your wife has a heart disease or you have a heart disease. Then hell freezes over. You can say that so much of problems happen, and they really need a lot of support. They need a lot of care, but unfortunately, many of them come very late. So 60% being diagnosed with the heart disease was an eye opener, and this is particularly true of developing nations like us. So where it makes us the importance of having a pre-conception counseling, what your Fogsi president is focusing on.
Yeah, that's
so how before getting pregnant, how we can, in fact, we had presented our data from MPAC on congenital heart diseases and the role of preconception counseling. And we had published in International Journal of Cardiology, where we showed that those women who had a preconception counseling, they had an improved obstetric and fetal outcome, though the numbers were less, 280 patients. So it was not a statistically significant benefit from the cardiology outcomes, but still they had a better outcome. So preconception counseling gives us an opportunity to first diagnose the heart disease and optimize the heart disease so that we can optimize the medications, everything, so that pregnancy process sails through smoothly.
Yeah, so the preconception care is so very important, especially in the case of these chronic medical disease or congenital heart disease.
So this was the first thing that we noticed. This another important finding that we noticed was, from India for the first time, we could identify those risk predictors for maternal complications, including maternal death. So we were using the Western data, let's say the Cardio-Obstetrics data from Canadian hospitals, the Sahara data, which is a retrospective data from Belgium. So these were what was available when we started the data in 2016, when Cardio-Obstetrics 2 was not published. Cardio-Obstetrics 1 and Sahara were there. And some data from the ROPAC group from 2013, from about, I think, 1,600 patients were there. But we, for the first time, realized that patients with mechanical heart valves, patients with left ventricular dysfunction, and patients with pulmonary hypertension, these are the patients more prone for maternal death. In addition, patients with severe mitral stenosis and patients who have first-time diagnosis of heart disease, these are the patients more prone to get maternal complications during pregnancy. Of course, we were a center which we could identify mitral stenosis and do antenatal balloon mitral valvotomy. As a result, it was not leading to death, but then of course, it was recorded as a complication. So we could identify the maternal complications predictors from Indian population.
That is amazing. So, sir, Tamil Nadu Pregnancy and Heart Disease Registry and NPEC India study have set global benchmark, I think. So how does these registries actually are influencing the real world clinical scenarios and in shaping the national guidelines?
Well, we in the MPAC registry, Madras Medical College registry, we didn't really have a cardiopstic plan or anything. So we were just working and collecting the data. And that was the time we realized if we work together as a team, we can do better. So next we started the Tamil Nadu Pregnancy and Heart Disease Registry. That was in 2019-20 when we started that. We ensured that in every center, 29 sites we chose in Tamil Nadu, We had 7 private hospitals and 22 public hospitals. In all these places, we created cardio-obstetric groups. And all these places, we also focused on improving the care of those diseases, particularly prosthetic heart valves. And we could show that by working together as a team, the maternal complication rate significantly came down when compared to the original Madras Medical College registry. And the prosthetic heart valves adverse outcome significantly came down. So this was a comparison of the previous data with the current study. So we realized in NPAC India study, if we design a protocol for Indian healthcare setting based on Indian data, and we verify if this data could improve the care compared to the usual care that is currently being followed, then this can become the guideline for managing pregnant women with heart disease, and we can present to the government of India, and as a Indian citizen, we'll be doing something good for our nation. So that is the idea that designed was the reason behind the formation of the NPAC India study.
Yeah, and with that, the study's outcome, maybe we are able to standardize the protocol
Care pathways.
for the cardio-obstetrics care in India, and maybe it can be accepted globally also. We are usually following the Western countries. It is very good to have our own data and our own protocol, and we look forward to it through NPAC study. Sir, you have also initiated cardio-obstetric master classes. So have these training program helped empower the young doctors and bridge the gap between different specialities?
I think that was an outcome of this interest that we had. We realized that when we manage a case together as a team, we learn a lot. We learn a lot from each other. So we thought, why should we restrict the learning to ourselves? So what we learned in Madras Medical College today, or what we learned in KM Hospital, Mumbai, or what you learned in RIMS Ranchi should not remain there. If we discuss the case in a common scenario with the experts from cardiology, obstetrics, obstetric anesthesia, cardiac surgery, and as necessary, and we can discuss the challenges that we faced and how we overcome them, and or what flaws we made, because we learn from each other, and that learning, if we discuss, everyone who is listening will be benefited. So this was the idea. We started the Cardio-Obstetric Masterclass, and almost we have conducted 10 Cardio-Obstetric Masterclasses. We initially chose those patients where the complications were very high. Like we have discussed prosthetic heart valves, we have discussed heart failure with dysfunction, we have discussed pulmonary hypertension. So wherever we found the complication rates were high, we discussed that, and there has been a very tremendous learning. And people, and we have uploaded them in a Cardio-Obstetrics India YouTube channel, and we have a lot of positive responses. People do share with us that what they saw in the masterclass, they were able to apply in their own practical learning, and it was able to improve the care process.
That is amazing. So, sir, Tamil Nadu's heart attack management program is often cited as public health success story. So, how did your experience in implementing this large-scale initiative shape your approach to cardio-obstetrics as well?
Basically, the interest in research basically stems from what we see in the clinical practice.
Yes.
So
research question comes from practice sometimes very often.
They're clinicians, as you said. Sorry, please go ahead. You said something.
No, sir, I was just telling the research question comes from OPD settings, your clinical cases only. So
exactly. So this research, this passion to do something about it came from a personal experience for a heart attack. So in 1995, I was a fresh MD graduate. And as Madam said, I was in Tirunelveli, and my dad had a heart attack. So, he continued to have pain, and we didn't have a cath lab. He was a fresh graduate, and finances were also very tight. We didn't know what to do. So no cath lab in Tirunelveli, and the next available cath lab was either in Vellore or in Trivandrum or in Chennai. So we managed to shift him to Chennai from Tirunelveli, which is about 650 kilometers. And we managed to organize funds. So I practically had experienced it. And God's grace, I would say, there's an opportunity that came. We could partner with the team called STEMI India, the government of Tamil Nadu, and we designed a study where we could develop a hub center with a cath lab and spoke centers that without cath lab, they could develop, thrombolize the patient and ship them for the angiogram. We found that it was a very successful model. Then my dream, why can't we do that for the entire Tamil Nadu? So we decided, I sat with my PGs, and we planned a geographical networking of Tamil Nadu. I presented the secretary, health secretary, and he was so happy. Immediately he approved it, and the National Health Mission of Tamil Nadu, they really did a great role in supporting that and taking it over, and we implemented it, and we are now running the successful Tamil Nadu government, STEMI care system or heart attack management program. So that was a practical felt need, and we could test it as a pilot,
Transform.
and then we could this is a Tamil Nadu government's healthcare policy now. So now the same way we found that in the cardio-obstetrics, the felt need, and we did a trial to collect the data in Tamil Nadu. We tested the feasibility of a cardio-obstetric care in Tamil Nadu pregnancy and disease registry. Now we are testing it to show the efficiency in the NPAC study, and hopefully, God willing, if it comes out well, it can become the GOI protocol. That is our dream.
Yes, just like heart attack management became the Tamil Nadu government protocol. We do hope that our NPAC study results into Government of India protocol. We look forward to it. So you have been part of many national policy reforms and you have been able to reduce the stent prices to designing cardiac care protocols. So how can we strengthen the policy research practice synergy in maternal health also? Like some innovation or
well, the innovations, I will say that, if one of my dream, in fact, the aim is that we should say, particularly since I am focusing on, say, pregnant women with heart disease and cardiovascular disease, which includes hypertensive disorders of pregnancy. Currently, we are not really including hypertensive disorders of pregnancy in the study, but, my colleague is awarded a PhD. Dr. Annie has been awarded a PhD grants from ICMR for working on hypertensive disorders of pregnancy, 50 lakhs. So she is starting the process also. These are the important areas where we as cardiologists can contribute contribute to improvement of maternal health care in this area. So if we have a protocol, and we could include that in a web-based or mobile-based application, which could be distributed to, or any doctor practicing in India should be able to access it. And we should also be able to provide a mobile application for the patients. So whatever information that they need and whatever information the doctor needs, so you do this testing, you refer to this particular place, those kind of information, and including the risk scoring system, the India-specific risk scoring system, and the healthcare facilities available nearby, all guided by AI. If it works together, that will definitely contribute to reduction of maternal mortality in our country. As you know, we are going through obstetric transition, which means that now, if you look at the West, 25 to 35% of all maternal deaths are related to cardiovascular disease. Our heart disease is the largest non-obstetric cause of maternal death. Now, in India, maybe I'll say in Tamil Nadu, when we started the study in 2011, it was about 4.5% was the contribution of heart disease to maternal death. And our MMR had significantly come down below 50 from 120, 130 by the hard work of our officials and the obstetricians. Now, when it come down from 120 to 45, the cardiac contribution increased from 5% to 10%. So this is likely to go up across the country. So unless we focus on improving the cardiovascular care of pregnant women, we cannot afford to bring it down to 10 and 5 for the country. So this is very, very important from a public health perspective. That's the cardiovascular care of pregnant women should improve. That is one of the thing that we as a nation should focus on to reduce maternal mortality.
Yeah, we are also into the era of obstetric transition where indirect causes are more contributing to maternal mortality. So, of course, developing new protocol in cardio-obstetrics is going to reduce maternal mortality. And sir, how can Foxy and cardiology societies collaborate to make cardio-obstetrics a routine rather than a care? So maybe is it possible in every tertiary hospital in India? With 56 centers in NPEC study, I think we can take it to all the tertiary centers in India.
Exactly. So in fact, we had published an article in Indian Art Journal, Cardio-Obstetrics, Why Does India Need This New Subspecialty? In
Oh,
that, we had worked on how to develop cardio-obstetrics systematically in the country. We had given various ways. One of the ways is how Fogsi should interact with the cardiologist, and how cardiology society should interact with obstetricians, and how these joint societies should have joint conferences. My dream is that in every Fogsi annual conference, or state conference, or the VP conference, there should be at least a 1 hour cardio obstetrics session. And already, I think in the South, the last couple of VP conferences, there have been a 1 hour sessions. I think the one happened in Kodai or recently in Kanyakumari. We all had a 1 hour cardio obstetrics sessions. Similarly, I want it happening in the national level as well as in the every various VP conferences and the state conferences. In the Cardiological Society of India, they have been very kind to allow us a 1 hour session on cardio-obstetrics from 2023, 24, and this year also we have 1 hour cardio-obstetrics sessions. Now, one more important thing that I want is that in the cardio-obstetrics session, obstetrician should come.
yes, sir.
We had one obstetricians in the Cardiology Society of India, and the previous time also I had invited. So we need to have at least two of the 5, 6 speakers should be obstetricians in the Cardiological Society of India, and two of the 5, 6 speakers of cardio-obstetrics session in Foxy should be cardiologists. We can have an obstetric anesthetist too, or a cardiac surgeon too. So that way we can work together and then join position statements. We are now coming out of the position statement from the Cardiological Society of India. We should work together and develop joint systems of care and working together, collaborative council meetings, all that are extremely important to develop this field in the country.
Yeah, that is a wonderful idea to have 1 hour session of involving both obstetrician and cardiologist in either of the conferences. So that is a brilliant idea, sir. And sir, on a personal note, what keeps you motivated in this long pioneering journey? Research, patient care, or seeing a mother and baby both safe at the end of high-risk pregnancy? It has
I
been
think
a long journey for you.
you gave the answer in the last question,
Yes.
I just remember one
Last one.
day, the last part of your question gave the answer. We had
Yes.
a twin patient with a severe dysfunction, and we had a very tough time with her. And finally, God's grace, we managed to save the patient. And when the patient came to us for the follow-up with the two babies, one in each hand with her husband, it was such a joy to
Yeah,
see them.
absolute joy.
The joy of seeing a mother happily, a very high-risk mother who would have otherwise died,
Yes.
going safely, smiling with her baby. I think that itself is a big motivation for the next couple of weeks or months for the hard work. I think that is the greatest motivation that we can have. And above all, you have a satisfaction that you are doing something good for the society, something good for the nation. And at the end of the day, you can be happy that, you had a purposeful day.
Of course, that is the thing which keeps all the clinicians motivated all the time. Seeing your patients, and especially the mother and baby, healthy and happy, that is the greatest motivation for us. And sir, because I'm a quiz committee chairperson, the last part of my podcast has a rapid fire round. So I'll be putting some one-liner or one-sentence question for you. So one word that defines cardio-obstetrics for you.
Integration.
Yes, integrating both the specialities. The
Yeah,
most
it's one word is
memorable,
integration. Yes. Yeah. Right.
most memorable case you will never forget. This cannot be one word, maybe a little longer one.
This was a patient with a critical double orifice mitral valve, severe mitral stenosis, and multiple heart failure episodes, not suitable for balloon mitral valvotomy, high risk for surgery. Finally, we took her for a balloon mitral valvotomy. We could manage, but then she developed severe MR. Cardiac surgeons were on the standby. Our obstetrics team from IOG was there in the cath lab, and we immediately shifted to the cardiac surgical theater. The obstetrician did the cesarean. The cardiac surgeon did the mitral valve replacement, and out came the patient
This
and the
same
mother and the
sitting.
baby alive, same day.
Oh,
So,
okay.
that, I mean, I can remember many, many cases, but this just came to my mind when you asked me.
So research or clinical practice, your first love.
Clinical practice.
Of
Because
course, because without clinical practice, you cannot have research.
that is who I am. And from there stems out the research. The
Yes,
clinical practice identifies a gap, and we do research to fill the gaps.
absolutely. A woman leader in medicine who inspires you a lot.
Padmavati madam, well, she's no more, but then the first lady cardiologist, she's
Okay.
a phenomenal lady, and she inspires me. Maybe internationally, Dr. Helen B. Taussig, but both of them are not there. If you say a cardiologist who's there now, maybe women cardiologist, I will say in the international community, Dr. Oksana Mehra, and maybe in India, I'll say Dr. Anita Saxena. So these are all seen. I'm only talking about the cardiologist. I'm sorry, you asked me for cardiologist, right?
Yes. In medicine, yes, of course,
Yes,
it could be
of course.
cardiologist also. One thing every young cardiologist must learn from the obstetrician.
One thing every cardiologist should learn from the obstetrician.
From us,
From
from
you as well.
obstetrician.
I will say patience and
Yes.
perseverance.
Patience and perseverance. That was also coming to my mind because patiently waiting for the mother is pushing and pushing and the baby is not coming out. Sometimes it is an obstetrician distress as well, in addition to maternal and fetal distress. But that patience sometimes helps. Your favorite quote or mantra for teamwork?
Together we win.
Yes. The proudest moment in your professional journey so far?
Well, maybe, when I was selected for DM cardiology, my dad gave me a hug. It was in 1995.
There are sometimes lifetime memories. If not a cardiologist, what you would have been?
Maybe a health policy researcher and implementer, maybe something.
Okay. Coffee or long walks? What is your stress buster?
Coffee, a long walk. Only these two options. And then in that case, coffee.
But as a cardiologist, I thought you would answer long walk.
No, I mean, long walk, the place that I live, I can't really go for long walks. So,
Okay.
otherwise, if I really think that I've done something good, I'll sit and watch a movie with my wife.
Yes. And then your last question, your dream for Cardio-Obstetrics India in one sentence.
A cardio-obstetric unit in every hospital that cares for high-risk pregnancy, guided by a protocol, oriented towards one singular end, healthy mother and baby smiling back home.
Wonderful. So it was great interacting with you and listening to your ideas, your vision. We do hope that the impact a study comes out with a great outcome with a new Government of India protocol, which is accepted worldwide also. So with this, we come to the end of our podcast. Thank you so much for joining and enlightening us with your thoughts.
Thank you so much, Dr. Archana. Thank you, Fogsi, for this initiative, and thank you, listeners. Thank you.